I was just waiting for Berta to come. Hey there. All right, well, good afternoon and welcome. Thank you for coming to the center virtually. I'm Carolyn Merrick, Program Coordinator, and it is my pleasure to introduce to you Dr. Jonathan Pan, who's going to speak to us about cardiovascular health. Cardiovascular disease refers to the conditions that affect the blood vessels and the heart. And in adults over the age of 60, at least 70% have cardiovascular disease, most of which is preventable. So we're going to listen to Jonathan Pan. He's an internal medicine, resident at the University of Virginia Health System. And he's going to help us understand the basics of cardiovascular disease and learn how to improve our cardiovascular health. Jonathan is a UVA Medical School graduate and a center volunteer. And next year he will begin his training in cardiology at UVA. And a little birdie told me, Jonathan, it's your birthday today. So happy birthday.
Thank you. I can't think of a better way to spend my 30th birthday. All right, so let me share my screen. All right, so thank you everyone for coming, and I appreciate everyone's time. So I guess Caroline had given me a very, very good introduction. Here's a picture of me starting medical school. And I remember one of my favorite memories of starting medical school was meeting two people who've definitely changed my life, Berta and Elaine. I actually was assigned to volunteer at the center, and that's where I met them. And we've had really a wonderful friendship since then. So we're going to first talk about the basics of just cardiovascular disease. I think there is it kind of encompasses a lot of different conditions. It includes what we think of as heart attacks, strokes, also poor circulation to the legs or other extremities. And then these other conditions that we refer to as heart failure, abnormal heart rhythms or arrhythmias, and heart valve diseases. The first three are what we're in many ways very interested in because they kind of have a similar mechanism in which they involve fatty plaque that develops in the heart and the different blood vessels. And so, on the left, you can see just normal blood flow that goes through blood vessels. And over time, with age and diet, you actually start to develop some fatty plaque that grows over time to the point where on the right side, you can see that people actually have poor blood flow related to these fatty plaques that develop over time. And this is kind of the term of atherosclerosis, which I'm sure many of you have heard of. And you have blood vessels that go everywhere in your body. And so as they get kind of full and with this fatty plaque and you get poor blood flow, you have higher risks of stroke. You can develop heart attacks and sort of this poor circulation. And the heart, we kind of think of it as just a pump, but even the pump itself needs these little blood vessels to have enough nutrients to pump blood forward for the rest of the body. And even those are susceptible to fatty plaque that develop. And so, heart disease and cardiovascular disease is probably one of the most important components of healthcare in the US. 1 in 3 American adults have at least one kind of cardiovascular disease. It's the leading cause of death, at least heart disease is. 1 person dies every 36 seconds. And then in older populations, particularly above age 75, 2/3 of cardiovascular deaths occur in this group. And you can tell that it's so age dependent that the percent of the population that have cardiovascular disease goes up and up over time. To the point where almost 85% have at age 80 or above have some sort of cardiovascular disease. And it's a cost thing that comes up a lot too. In 2011, about $316 billion was spent on cardiovascular disease. And to give context, at that time, the economy was about 15 trillion. So it's a pretty large sum. And that's about 1 in 6 healthcare dollars spent on cardiovascular disease. So here's a picture at the yard sale. I think it's the yard sale at the center. And this is Marge, and she's clearly very amused at me double and triple counting the dollar bills in the deposit box. So now we're going to talk about the individual cardiovascular diseases, because I think when we hear about cardiovascular disease, we kind of get lost in all the different types. And so I think it's easier to break it down to the main types. And going back to what I first said, a lot of it starts with fatty plaque that builds up somewhere and causes, either poor blood flow to the heart or to the brain or to the other arteries supplying different organs, including your legs and your arms and your kidneys and even your gut. The one that we think about a lot is coronary artery disease. Like I said, your heart, just like any other organ, needs good blood flow to the actual muscles so that your heart can pump. And initially when you're born, your arteries look nice and clear, but over time, based on what you eat and also just general wear and tear, you develop these fatty plaques around it, and eventually reaches a point where it stops blood flow, or at least does not give enough so that you can have good heart function. And so the main thing that symptoms that people have when they have this coronary artery disease is they have chest pressure or pain that is pretty deep in their chest. It gets worse with exercise and gets better with rest. And this is something that's been studied for probably over 100 years, in that even during, before a lot of medical knowledge was known, this was the typical chest pain that people would have when they had coronary artery disease. And then there are some more atypical symptoms in which people can have intense sweating, trouble breathing, or pain that goes up their arm or down their arm, to their shoulders or to the neck and jaw. And there's kind of two types or flavors of coronary artery disease. One of them is termed this stable angina, and that's where you get this gradual blockage that accumulates over time, and it gets to a narrow enough lumen in the heart vessels that you actually feel short of breath and you have this chest pain anytime you exert yourself, but it's stable in that it happens consistently every time. And then the heart attack that we hear about a lot is when this plaque becomes big enough, or just all of a sudden ruptures and opens up, and then it causes a lot of inflammation and clotting that completely occludes off the coronary vessel, and that's known as a heart attack. So that is something that occurs suddenly, where you have this chest pain, but the characteristic is still the same. It's worse when you're exerting yourself and better when you're resting, but it's very sudden, and it's a lot more intense and painful. And so when when these two happen, if you have stable angina where you're just gradually noticing you're having more and more sort of chest pressure when you're exercising, you should really talk to your doctor about that. And when you have sudden chest pressure, like someone sitting on your chest, it definitely gets worse when you exert yourself. You should call 911 or go to the emergency department, because that is a medical emergency. So the next cardiovascular disease is stroke, and it's the same concept in which you get fatty plaque that develops, and eventually it can cause a blockage to blood vessels that supply your brain. I think there's sort of two types of stroke that people talk about. One of them is ischemic stroke, which means poor blood flow. And the other one's hemorrhagic stroke, in which you have a bleed in your brain. Usually when we talk about strokes, we mostly talk about the ischemic or poor blood flow kind of stroke, because that makes up about 85% of strokes. And when you have a decrease in blood flow to your brain, it can cause issues like trouble speaking, paralysis, numbness, severe headaches, being unable to walk, and vision changes. The thing that's tough about a stroke is sometimes there are other conditions that can mimic a stroke, headaches, or migraines and other neurologic conditions. And so the main guidelines that they recommend people is to use this mnemonic act fast, in which if someone is having facial droop, they're having one arm weakness, and that when they try to raise their arm, they're only raising one arm. And when they're trying to talk, if their speech is garbled or not making any sense, when they have all three of these, the likelihood that they're having a stroke is very high, and that you should call 911 and get to them to the hospital.
Hey, Jonathan,
Yes.
a quick question back to heart attacks. Years ago, doctors said that the symptoms were different for women. I believe women tended to have pain in their arms and not in their chest. Could you please address this? Vicki wants to know.
I think that's a really good point. And there's been more and more research coming out addressing the fact that women have what people describe as more atypical symptoms. But it's a little bit of a confusing topic, because most of the original research done in heart disease were done in Caucasian males. And so it's not very clear how well a lot of it translates to. And then there is some concern that there may be bias associated to how men and women or people of different races are treated. And so it's not clear if it's truly atypical symptoms or the way that we're perceiving or working with the symptoms that are being brought up. But that's why, typically the chest pain is in this nature, but the other symptoms are still what we often call anginal equivalents, so equivalents of chest pain. And we are very cognizant of that when it does occur.
Thank you.
So going back to stroke, so I said that, typically the fastest way to think about if someone has a stroke is whether they have facial droopness, arm weakness, and trouble speaking or slurred speech. There's a term that I think a lot of people have heard is mini strokes or transient ischemic strokes. And just to help clarify, essentially it's where there is a temporary blockage of blood flow from a clot. And the reason why it's a mini stroke or transient stroke is the fact that usually it is not permanent, it's temporary. And about 80 to 90% of these mini strokes, the symptoms go away after 10 minutes. But it's still very clinically important to us, because 1 in 3 people who have mini strokes are going to have a full stroke later. And the thought is that sometimes you develop these clots, which you can see in this picture, that move, and they may have formed in a certain way where it causes a stroke and then moves again where the blood flow opens. But the thought is that clot is still there, and it may transform into a full stroke later. So the next cardiovascular disease is peripheral artery disease. And this is sort of what we often refer to as having poor circulation. And the disease mechanism behind this is the exact same, in which you get fatty plaque that develop in your arteries and slowly either block the blood flow or can rupture and cause a clot to block the blood flow. And the typical symptoms that you have with this is cramping in your legs when you walk, but it gets better when you rest. And sometimes when you have too much blockage or narrowing of the blood vessel, you can start having wounds or ulcers that develop that don't heal well because they don't get good blood flow. I think an important distinction is that this peripheral artery disease is different from a deep vein thrombosis, or what we often call a DVT. And the reason why is that you have two types of blood vessels. You have arteries and veins, and arteries go away from the heart, and they send oxygenated blood to all the different organs. And veins bring that blood back to the heart so that it can go back into your lung and be recirculated with more nutrients. And the DVTs, or deep vein clots, that we talk about are actually in the veins. And when we think about peripheral artery disease, it's actually in these arteries that go away from the heart and towards the organs that they're trying to supply. So here you can see, if these arrows represent the direction of blood flow, the arteries are taking blood away from the heart and going to the legs and the feet. And here, the arrows going away are taking blood back to the heart. And so it's important not to confuse those two types of diseases because they are treated differently. And then a couple other cardiovascular conditions that we'll talk about that are related, but not necessarily through fatty plaques, include heart failure and valve diseases. And so heart failure essentially means that the muscles of the heart are not squeezing as strongly as they should. And because of that, you don't really get good blood flow to the rest of your body. And valve disease is where the different valves of your heart, so you can kind of see in this picture, the little circles are representing the valves. They make sure that blood only move in one direction. Just like how any other valves work. But you can get diseases in the valves where either they don't open all the way, as in it makes it really difficult for blood to move forward, or they don't close all the way and you actually get backflow of blood. And even though the diseases are very different, the symptoms and the effects are similar, in that overall you get poor flow of blood to the rest of your body, and you can actually accumulate or build up some fluid or sort of backflow of fluid because you're not getting very good cardiac output. And so because of that, the symptoms are often very similar. You can have troubles breathing when you're exercising or becoming very short of breath, or when you lay down, your body doesn't equilibrate fluid well, you can feel short of breath. You can feel fatigue and weak, and a lot of people will have swelling in their legs and feet because they are getting almost sort of a backflow or a backup of fluid into their veins. And so here's a picture of a person, and they have heart failure, in which their heart is becoming more enlarged because it can't really keep up with the squeeze and the fluid backup. And because of that, he's developing a little bit of fluid around his lung and some swollen legs. And then heart arrhythmias is a very, very large and broad cardiac disease, cardiovascular disease. But to kind of summarize it, essentially you have electricity or electrical signals that travel through your heart from an initial point, the sinus node, and it travels down to signal to the rest of your heart to squeeze in a coordinated fashion. And when you have issues with any parts of the circuit, you develop a heart arrhythmia. And so you have these abnormal conductions of heartbeats. And sometimes you can have too slow of a heartbeat, as in you're skipping beats, or the rate is set too slow. Or sometimes you can have too fast a heartbeat, in which Your heart is pumping very, very fast, but not very efficiently because it's working too fast. But the main thing is that these abnormalities can originate at different parts of the heart, either in the top or bottom chambers. And so the causes of heart arrhythmias or abnormal heartbeats is very broad. It can be from prior heart attacks that you've had. It can be from heart failure. It can even be from different types of infections. Sometimes people have genetic diseases that predispose them to have heart conditions. And then just any other organ can cause heart-related issues, sometimes related to abnormal electrolytes or abnormalities or hormones or different toxins that build up. And then finally, unfortunately, with age, you also just have a higher risk of developing abnormal heart rhythms. And the symptoms can vary a lot. For some people, they actually will not feel any abnormal heart rhythms, even when they're having it. For some people, they have palpitations, which kind of refers to feeling really strong, intense heartbeats or like their heart is racing. Some people can have lightheadedness, chest pain, troubles breathing, even a sensation of anxiety can come about from arrhythmias. And then for certain type of arrhythmias, you can have fainting or even sudden death. And so on the left, you can see sort of what we call electrocardiogram or EKG, in which a lot of times we'll order this for someone where we're thinking may have an abnormal heart rhythm, and we will screen them based on this as a first test. So here's a picture of Berta and Elaine and Bill, and every year they would do a pizza outing at the end of our volunteer session. I think this was the year before I had met them, but it also looks like a very fun group and probably one of my best memories of the center.
Jonathan, oh, that was, yours. Next slide. Well, this one's fun to watch too.
Yes.
A while back, Bruce asked, are there tests that can identify potential problems before they occur? And that looks like what you're going to be addressing next.
Yeah, I'll go over what we do to prevent heart disease. And then if it doesn't answer your question, you should definitely let me know, because I didn't go too much into specifically testing for heart disease, more how can we prevent heart disease from progressing.
Great, thanks.
So the different causes of heart disease, it's very, very multifactorial. You can have high blood pressure, high cholesterol, smoking, not exercising, obesity, diabetes. And then on top of that, there is a large genetic and family component. In that, if you have a family member who's had a heart attack at a very young age, like in their 30s or 40s, it is sort of recommended that that other families should think about more early heart testing or modification of risk factors. So when we go to clinic, we try to calculate someone's risk of cardiovascular disease. And this is mostly validated, I think, for ages 40 to 70. And it's more beneficial to do this at the earlier age. But I think this is helpful to see what goes into this risk factor calculator. And this helps us predict the likelihood that someone will have a cardiovascular event, as in like a heart attack or a stroke or something else related to heart disease that makes them very sick in a 10-year period. And so this includes age, their gender, and their race, which obviously those things you can't really change. And then also blood pressure, cholesterol, whether they have diabetes, whether they are smoking. Those are the things that we use to help calculate this. And then below, which I didn't include, were also medications that whether they're taking or not. So the first thing is cholesterol. And cholesterol is really important because it's the part that makes up a lot of this fatty plaque that we talk about that can cause narrowing blockages or can even rupture and cause acute events in which you have blockages in blood flow. And so when you go to the doctor and you get your cholesterol report, the things that you usually get in the report is the total amount of cholesterol, the amount of LDL cholesterol, which is sort of what we refer to as the bad cholesterol, the amount of HDL cholesterol, which is what we call the good cholesterol, and triglycerides, which are more, it's more of a measure of fatty components in the blood rather than cholesterol. And overall, your goal is you want lower total cholesterol, lower bad cholesterol, and lower fats and higher good cholesterol. But I know that we've talked about higher good cholesterol in the past, but really the goal is lower total cholesterol and bad cholesterol and fats. And so I think the benefits of good cholesterol are there, but not as important as really lowering the total amount of cholesterol and the bad cholesterol in your blood. And so the mainstay of trying to improve cholesterol starts with weight loss and exercise. And then based on the calculator and other people's medical conditions, especially if they have high cholesterol, is to start a statin medication. And I'm sure that most of the people here have heard of statins. And I think statins are always a tough medication. The evidence for statins are very, very good. Here, if you look at this top figure, the axis, the left shows non-fatal heart attacks and cardiovascular disease percent. And the bottom axis shows years. And so the placebo group, they had much higher risk of heart attacks and death from heart disease. In the statin groups, they had much lower risk that continued over time. And even outside of heart disease or heart related events, just total deaths alone, there is a benefit of being on a statin. But I think that we as doctors always get in trouble with and always get yelled at by someone is the fact that it can cause muscle aches and it can make people feel bad. Very rarely there's a risk of liver disease, but it's definitely on the lower side. And we do kind of check liver function, but I think muscle aches is a big issue that causes trouble. But we have different tools to try to prevent it. We will try different formulations. There are a lot of different types of statins. And then we will also try to adjust the dosages and even the frequency just so that we can get to the right level where people are still getting benefits from a statin, but not having as much muscle aches. And there are a couple alternative medications approved by the FDA that we can use to help bring down cholesterol too. But really statins is where we start. The next medical condition that's really important is diabetes. It's very strongly linked to cardiovascular disease. And I'm sure all you guys know of someone who has diabetes, but for those who don't know too much about it, it's essentially where you are unable to control your blood sugar levels with the insulin that you're making. And on this picture on the left is these little keys, and those are basically like what insulin does. They act like keys to help blood open the cells so that they can use the sugar in your blood to make energy. And with diabetes, the keys just don't work as well. And so you have really high blood sugar in your blood, but you're not really using it very well. And the reason why we care about diabetes is because it's a very important risk factor for early cardiovascular disease. in some time, and in some places, it's almost considered to be equivalent of heart disease, in that if you've had diabetes for long enough, a lot of people will assume that you probably have heart disease too. And for those who do have heart disease, if they have diabetes, they will actually have more extensive heart disease because of it. And the reason why that happens is, diabetes, it has the high blood sugar, the high amounts of sugar in your blood will actually cause some damage to the blood vessels. And that's more of the direct effect. The indirect effect is the fact that people with diabetes tend to have more issues with high cholesterol, high blood pressure, and obesity. And we know that those are also definitely risk factors for heart disease. And it's the fact that diabetes sort of clusters around those medical conditions that puts you at higher risk of heart disease. And so the treatment for diabetes is sort of what you would expect. Starting diabetes medications, sometimes starting insulin pills or pills that help your body secrete insulin, checking blood sugar. And then for people who need more control of their diabetes or blood sugar, starting insulin injections. And so in my clinic, and sort of the standard protocol is that anyone who has diabetes, I order them a glucose monitor so that they can check their diabetes and their blood sugar levels at home. They get a metformin, which is sort of the foundation of medications that we use for diabetes management. And they actually, it's recommended that anyone with diabetes should be on a statin because of that, what I had talked about before, where people with diabetes tend to have issues with cholesterol and heart disease. And so the benefit of a statin is pretty well known in diabetics. And then based on that, I continue to adjust medications, maybe adding more medications down the road. Next is blood pressure. And so blood pressure is definitely an issue that tends to get worse for a lot of patients as they get older. There's been a couple recommendations of what blood pressure goals should be, but generally this orange line is where you should start treating blood pressure. Is once your blood pressure goes above 130/80. And this is the recommendation by the American Heart Association. And so the reason why blood pressure is important is because this high pressure in your blood system tends to damage the vessel walls of blood vessels and also the heart, and it predisposes you to have more cardiovascular events because of this damage that occurs over time. And so our goal for blood pressure is to have a blood pressure less than 130/80. And the ways that we do that is through medications, through diet, and particularly there's one called the DASH diet, in which the goal is to have less than 2 grams of salt, because salt tends to cause more retention of water, and that retention of water leads to an increase in your blood pressure. And I think salt is something that we talk about a lot because nowadays most food is very heavily processed. And so we tell people to avoid processed foods, and when they cook, to try to not add any salt, because it's very, very easy to reach this 2-gram limit of salt. And then secondly, exercise and weight loss are important parts of controlling blood pressure. The one thing that becomes an issue in clinic is that as we control people's blood pressure, we do run into an issue that sometimes people get lightheaded and dizzy because their blood pressure is too low. And so there are times in which we have to compromise and say a little bit higher blood pressure is okay as long as you're able to safely walk and do your activities. But still, the goal is to get to 130, less than 130/80 if we can. But if you're having too many symptoms, we can always work on a middle ground. So next is weight. Weight we define based on body, or whether you're overweight or obese, we define based on body mass index, which is we generally say greater than 30 of a body mass index is considered obese. And the body mass index is just a ratio of your weight to your height. But there is also this concept that people have different body shapes, and so the body mass index is not perfect. You can have someone like a bodybuilder or someone very muscular who probably would be considered obese based on this body mass index, but what we know is actually fairly healthy based on the way they look. And so waist circumference is another way that we can kind of risk stratify people, where greater than 40 inches in their waist circumference for men and greater than 35 inches for women is linked to being overweight and a higher risk of cardiovascular events. And I think obesity is something that has continued to have a lot of media attention because it is sort of an epidemic, where in 2015 the prevalence was 40% of men and women were considered to be obese. And I think that number in many ways has only been getting worse. And weight and obesity is important because as you as you have higher and higher weights for your size or your height, you see that your risk of cardiovascular disease gets worse, especially for heart failure, for coronary heart disease, and stroke. And it's a pretty clear line in which, for as you increase in weight, your risk only increases. And so the treatment goals for being overweight or managing obesity is really focus on the complications, in that with obesity, you tend to have issues with blood pressure, diabetes, cholesterol. Also, it can affect your ability to exercise. And so our goal is to prevent those complications and to treat them properly, and if possible, to actually reverse them. And then secondly, a quality of life component. And so the main things that we do to manage weight is sort of what you would expect: diet, exercise, and then setting goals for yourself to lose weight. And then in gray, I kind of talk about, I also include medications and bariatric surgery, but those are really reserved for people who are failing this first step and having a lot of complications related to their weight. And studies have shown that people who even make what we would consider small weight losses of less than of 5% of their weight, there is a pretty significant health benefit. And I think it has to do with the fact that your caloric intake is trending the right way, and how your body's burning it, and it does give you a lot of benefits even for small amounts of weight loss. So I would never be discouraged if you feel like you're not losing a lot of weight, because the benefits are still there. And then next is diet. I think we live in a very diet crazed society in which there are so many different diets to do. And I think conceptually all the diets are pretty similar. And here are two diets that are listed by the American College of Cardiology. And they're more or less the same. One of them is the Mediterranean diet, and the other one's the DASH diet. And the emphasis is that you eat whole grains, fish and poultry or lean meats, vegetables and fruits, and then you are careful about the other foods that you eat. And so the overall goal is to have a diet high in fruits and vegetables, low in red meats, mainly focusing on lean meats, low in sweet foods, low in salt and fat, and portion control. And so I have this hand here because I learned in medical school a really helpful way of thinking of your diet, in that it, how much you're eating shouldn't be too much larger than your two hands combined, in which your palms are essentially the protein starch, and the vegetables and fruits kind of make up your fingers, in which you can expand those either bigger or smaller portions. But really, the important component of your diet should be the high amounts of fruits and vegetables, and the protein and starch or carbohydrates should be consistent. And then next we have exercise. And so they recommend, most cardiology societies recommend that you have either 150 minutes of moderate exercise a week or 75 minutes of vigorous exercise a week. And so to give in context, if you exercise 5 days a week, you could do either 30 minutes of moderate exercise or 15 minutes of vigorous exercise a week for 5 days, and you would be at goal. But it's not an all or none thing. Any exercise is good. You should always try to exercise when you can, even if it's just a little bit. I think it's a little bit confusing what moderate or vigorous exercise means. You can see they have official measurements at the top, and then they have different activity levels on the bottom that show what moderate and vigorous exercise is. I think it depends, because for some people, tennis doubles could be light exercise. For me, it'd probably be very vigorous exercise. And so it depends on who you're talking to. But I think the one way I think about moderate and vigorous exercise is that moderate exercise is where if you were talking while exercising, you'd have a somewhat limited conversation because you're short of breath. And if you're doing a vigorous exercise, you're basically not talking at all because you're so short of breath because it's so vigorous. And that's how I like to think of the difference between the two. Light exercise, you're probably talking the whole time because it's not much. I think one topic that I get asked a lot about is confusing is alcohol. I think many of you have heard that drinking wine or red wine is good for your cardiovascular health. And that's definitely, there's definitely studies to support that. But it's important to recognize that it's moderate use of alcohol. I've definitely met people who are drinking bottles of wine a night, and that goes into the classification of excessive alcohol use. And it's important to recognize that excessive alcohol use can cause actually more cardiovascular disease. It can make your blood pressure worse. It can even lead to heart failure. And for some people, it can make heart rhythms such as atrial fibrillation worse. And so the guidelines recommend that or consider drinking in moderation as 2 or less drinks a day for men or 1 or less drinks a day for women. But the key component is that just moderation. That's probably where you'll get your benefit, but this is definitely not a case where more is better. And then I think one of the most important components that I talk to patients about is smoking. Smoking alone contributes to 33% of cardiovascular related events in the US. And it does this in a lot of different ways. It damages the blood vessels, it increases the risk of clots, and can even make cholesterol worse. And it doesn't just affect the heart, it affects a lot of different organs, including the lung. And so whenever I can, I counsel people about smoking and trying to get them to quit smoking. Because the benefits of quitting smoking are very clear. You have a decrease of having bad events. What I mean by that is cardiovascular events like strokes, heart attack, or being hospitalized for your heart. That decreases anywhere between 7 to 47%. and you get a lot of the benefits by the first couple of years in which you quit smoking. But it's important to recognize that the damages from smoking does stay for a while, and that's why it's important to quit early. And for people who have smoked, it takes about 10 to 15 years of not smoking to reach back to the level of heart risk that is equivalent to someone who had never smoked at all. So the earlier that you quit smoking, the more and more you're going to get out of it. And then finally, doctor follow-ups. I think that what's really hard is that a lot of times we think of medical conditions as you get a disease and then you get a cure and you're done with it. But I think cardiovascular disease and all the risk factors associated are difficult and really hard to treat because they're chronic issues. And it's something that you have to work with your doctor and follow up often about. Heart disease, the fatty plaque that develops, it doesn't just kind of go away all of a sudden. It comes and goes. And when it does start to decrease, it's a very slow process, and same as when it builds up. And the risk factors too, diabetes, high blood pressure, cholesterol, those are all issues that have to be dealt with over a long period of time, and they don't completely go away. And sometimes they get worse even when you're doing things exactly correct, because a lot of them are just related to age. And so as doctors, our goal is to be able to track your progress, to make adjustments to your medications, and then also provide education so that you understand what we're doing and you're part of the plan, and you're also driving your own healthcare. And then on top of that, the medication component is definitely a really important part. And there's more and more research coming out about the different impacts of medications. So here is a study from the New England Journal about making sure that we use both cholesterol medications or statins and blood pressure medications. And you can see that both of them combined decrease your risk of heart disease and heart-related events better than them individually and better than doing nothing. And then in the last year or two, there's been a lot of talk about these new diabetes medications, and we're finding that those are also having a lot of benefits for the heart. Primarily what we call these SGLT2 inhibitors or these GLP-1 receptor agonists. But the point is, I'm very, very hopeful in the future of more medications that are going to be able to help us treat heart disease and prevent it. Not just directly treating heart disease, but also the other risk factors that we've talked about today. And so, most of these resources I kind of got from talking, reading on different websites. I think there's always a lot of information on the internet, but these are the few that I really liked. The CDC, the American Heart Association, the American Diabetes Association, Mayo Clinic, and the WHO. I think that the internet is only getting more confusing, but it's always good to know of trustworthy places to look for information. Another reminder is that if you haven't, you should definitely get your COVID vaccine. And here's a little bit of information, but a lot of the COVID vaccine you can get through the health department, the Virginia Health Department, and you can call them to set up a time to do it. And I would definitely do it early if you have not done it yet. And that concludes the presentation. I just want to thank Carolyn for setting this up, and then the center, which has always been very supportive, and I've had great memories. And then just the University of Virginia. I've been in Charlottesville for about 10 years, coming here for college, and it's truly been a second home. And I've really learned to love the Charlottesville community. All right.
Well, thank you so much. And we have time for some questions, and I've allowed people to unmute themselves. So if you want, you can either put a question or comment in the chat for Dr. Pan, or you can unmute yourself and ask your question. So anybody?
My
Bruce?
question before about tests was really, are there any, I'm imagining, imaging tests where there can be a visual indication of early buildup of plaque?
Yeah, that is a great question. There's one imaging test called a calcium score that is what a lot of people are using to help risk stratify patients. It's essentially a low radiation dose CT scan that looks through your heart and actually calculates the total amount of calcified fatty plaque in your heart. And it adds up all these different amounts of calcified plaque into a number, and then it actually scores you based on that total number. And that number tells you the likelihood that you may have a cardiovascular or heart event in the next 10 years or so. The one issue is I don't think it's covered by insurance. It is, I think, like a $150 test, but it is helpful because it helps us as either primary care doctors or cardiologists to decide how aggressive we should be about treating heart disease or preventing heart disease.
Thank you.
Question. We have a dear friend who was in his younger 50s, very fit, at least he looked fit from the outside, very athletic. He went to the doctor, had a checkup, everything's fine. And I'm sure you've heard this before. You know, he's riding his bike up the hill for his usual miles, whatever, and he stops, takes a break for water, and he dropped dead of a heart attack. So can you kind of explain how episodes like this would happen?
Yeah, heart disease is definitely complicated. So to give you an example, the fatty plaque that I talk about, we all have these fatty plaques, even at a fairly young age. And a lot of studies have shown that fatty plaques in the early stages of development have a higher risk of breaking open and causing these heart attacks. And actually over time, some of them will harden and calcify and they won't break open. Their risk of breaking open is very low, but they do continue to grow and they can cause this sort of stable angina. And my point about that is that, you know, for example, statins, they help actually harden some of these plaques and decrease the risk of these plaques from rupturing. But it's still very hard to predict who exactly, you know, which plaques will rupture and cause these heart attacks. The second part of your question is the fact that there is a large genetic component in which people who don't really have a lot of diseases still have high risks of heart attacks at early ages, either through cholesterol or just purely through genetics. And it's also hard to predict for those people. But that is why it's important to screen people early and to get a thorough history to determine whether we should start medications early or see them more often to adjust risk factors.
Betty, you're unmuted. Did you have a question, Betty?
Oh, well, I was just going to ask if you have on the blood pressure, say if you have 140 over 70, does the fact that the 70 is lower make it okay?
I think we usually want both numbers under that amount.
Yeah.
It definitely gets tricky because as you get older, your blood vessels become less, they become a little bit more stiff. And so sometimes the higher number, the top number will fluctuate a lot more with age, and the lower number will be a little bit more consistent. I think a lot of what goes into blood pressure measurements or blood pressure management is how you measure it. In that you're measuring consistently during one time of the day. You're making sure you rest long enough that your blood pressure will stabilize out, and then we're making adjustments based on that consistency. Because I think one thing that always is a little bit difficult is people come into the clinic and they're either afraid of hearing about their test results, so their blood pressure is high, or it's really hot outside, or they're running over to clinic because they're late, and then we check their blood pressure and it's really high. But that high number is normal because if you and I were running outside, we should have a high blood pressure. It's what we care about is the blood pressure when you're taking consistently in a calm state and whether it's still high at that point.
Okay.
Jonathan, I have a question. So, let's say you don't you've just gone to your primary care provider, you've not had issues with chest pains, etc., but you just want a baseline at some point in your life. How would you go about doing that? Do you have to ask your PCP to then send you to cardiology? Is that covered by insurance? Or do you have to have an issue to present that's a problem in order to get any kind of information about your cardiovascular health?
Yeah, I think that's a great question. I will say that most primary care physicians are very comfortable with managing and preventing cardiovascular disease. I think the exceptions where people will get referred to cardiologists without having heart disease or people who have difficult to manage risk factors. So we do send people to cardiologists when they have difficult to manage cholesterol or blood pressure. We even send people to endocrinologists to manage diabetes, or people who have like really significant family history of heart disease. We will send them to cardiologists too.
Thank you. And Carol, I noticed you're unmuted. Did you have a question or comment?
Yes, I think about all these things. There's some things that you've said that I don't agree with, but I agree with my GP. Would you not advise someone to find a GP they like, that they get along with and they trust, and go with what they say? Because I simply do not agree with what you say about taking an experimental drug for a disease I don't have. It's not a approved drug. The China thing, I won't do it. And my GP and I agree.
Yeah, I think overall the most important is that you have a good relationship with your primary care physician, and that you guys work together. Because at the end of the day, I think it's a shared decision making that you guys make together.
Thank you.
Berta.
Yes. Is there something other than heart disease which would cause lymphedema? I've had lymphedema on and off for about 30 years. Blood pressure's in good control, medicated but in good control. Diabetes too, but with an A1C of 6.2, 6.3. Is there something else that I should be looking into? I cannot do because of kidney problems, I cannot do the diuretics.
Yeah, there are some other conditions. So like accumulation of or swelling in your legs can sometimes be related to the lymphatic system. And so that's something that is not involving blood vessels. It's actually a separate drainage system that also has different ducts. that help drain fluid that goes outside of the blood vessel and around the cells and the tissues.
Yeah.
And sometimes people can develop swelling from that alone. There aren't a lot of good solutions for it. Still, sort of the recommendations are similar, in which elevating the legs when you can, using compression stockings when you can, and also
that. Yeah.
staying mobile. But that's sort of my
Yeah.
extent of knowledge of that.
Thank you.
Well, thank you, Dr. Pan. I appreciate your time and appreciate you all showing up here. If anybody has any more questions or comments, you can maybe write them to me and I can pass them on to you if that's okay with you. Thank you all
Have a
for
good
coming.
birthday, Dr. Pan.
Yes, happy
Marge
birthday.
Marge says happy birthday too.
yeah.
Here she is.
Oh,
Here
hello.
I am. It's great to hear you again, Jonathan.
Yeah, it's great to see you guys again too.
Thanks.
Thank you.
Well, thank you for your time, everyone.
Happy birthday. Thank you.
Bye.
Bye-bye.